to introduce our next speaker, who is very lovely, Joanna Feeney, who is the strategic manager at Fresh and Balance, presenting work that is being done there with local authorities. So this is really important, Joanna, because I didn't want it to be an all NHS focused webinar, and there's lots of community services who are desperate to get Varenicline and cytisine available in their localities. So some of the work that you're going to describe, I think, is going to be really helpful to colleagues on the call. So over to you, Joanna.
Thanks, Sanjay. Absolutely. And I think just to kind of add that, you know, we are obviously working really closely with our community pharmacy colleagues as well. So this is an approach that we have in the Northeast, which would be a PGD via a community pharmacy supply service. So I'm just going to share my slides if that's okay. So yeah, as Sanjay says, I'm Joanna Feeney. I'm the Stop Smoking System Strategic Manager at Fresh, and Fresh is the regional tobacco control programme that covers the northeast of England. So I've been asked to share what we've been up to in the northeast to enable the provision of Varenicline across our 12 community stop smoking services. And briefly, this is what I'm going to cover today. I'm going to talk through a little bit of the background context that led us on our journey towards this regional PGD. I'm going to talk about how our proposal was developed, highlighting some of the identified benefits and how we've gone about putting the plan into action. I'm also going to briefly mention our parallel work stream that's underway to ensure that Varenicline is also available within the trusts in the Northeast, and the timeline that we're working to deliver this on, as well as some of the challenges that we're facing. But I'm going to start with the caveat that this is all a work in progress. So this is just a little bit of a background. We have 12 local authorities, as I say, in the Northeast, and they deliver a range of different models of stop smoking services, including one that was in the middle of a retendering process back in March when we started this piece of work. At that time, cytisine had just come onto the market, and we were expecting Varenicline to be back on the market, as I say, in the autumn. The ICB had recently harmonised its formulary from a single ICB formulary from the 3 previous ones. But there had been a number of concerns that had been flagged by prescribers to the formulary advising group about it being confusing with contradictory, outdated information. So, for example, there were notes on to say that in some areas you couldn't prescribe this medication, or in other areas not prescribe this medication because it could only be issued by a certain stop smoking service. There was also a lack of clarity around, for example, bupropion, and all of this was just acting as a big barrier for prescribers across the Northeast and North Cumbria. So we felt it was the perfect opportunity to review the formulary with a view of adding cytisine, but also to update it to ensure that Varenicline and all of the other stop smoking medications were RAG rated as green, as suitable to be initiated in any setting, removing the outdated local commissioning information in order to reflect the changing landscape of the Northeast stop smoking system. So that was kind of acknowledging that stop smoking services were not the only ones that were delivering stop smoking support anymore. Within the Northeast and North Cumbria, we do put the person who smokes at the centre of everything that we do, so that they have the choice in how they quit and where they quit smoking. So this ensures that we can maximise that system-wide impact by having all of the effective stop smoking aids that were mentioned available in all of the services that we have. And we knew this wasn't going to be a quick process, from, as been mentioned before, getting the formulary updated, to agreeing the appropriate prescribing processes across the different services and settings, to ensuring that it's stocked in pharmacies, providing awareness and training sessions, and then the ongoing kind of review and monitoring of it. So what did we do? Well, we first undertook a mapping exercise of our local stop smoking services, looking at what their current processes are to issue medication. So, for example, where there were NRT voucher schemes in place, how they worked, did they have e-vouchers, paper vouchers, what systems were used, how they had previously provided Varenicline, whether they had any plans following the launch of cytisine, or any intended processes in development to support the supply of Varenicline once it was back on the market. We also did scope if there was interest in coming together as a region to have a single PGD. In addition to the Stop Smoking Service mapping, we also worked closely with the Tobacco Commissioners Network. Some of the tobacco commissioners did have previous experience with Varenicline PGDs and stop smoking services, though I think it's fair to say the majority didn't. Since the pandemic, we also received a lot of feedback that engagement with primary care and pharmacy had declined, and that there was limited capacity now within public health teams to kind of pick this up. There was also some concerns flagged that if areas reverted to the previous process of requesting prescriptions from GPs, that this would add additional barriers and delays for people who are wanting to stop smoking, and it doesn't necessarily result in this seamless pathway. And then finally, we had feedback from primary care prescribers who they expressed concern that they just did not have the capacity to respond to prescription requests from stop smoking services across the whole of the North East for both varenicline and for cytisine. So myself and the two public health pharmacists who were leading on this, we submitted the formulary review application with a note of intention that in the medium term, all of our stop smoking services would supply prescription-only medications such as Varenicline and cytisine independently without requesting prescriptions from GPs, as this was viewed as the biggest barrier to getting approval onto the formulary. The application was officially supported by the Smokefree NHS Task Force in the North East and North Cumbria, by all of our trusts, our clinicians, and also by the ADPH Tobacco Commissioners Network. It was submitted in June and was approved in October following due process of consultation and going back and forth to the different groups. So we then looked to work with our Tobacco Commissioners Network to look at, well, how can we move this forward in our stop smoking services? We formed a task and finish group and we looked to review the previous PGDs that had been in place in our region. We looked to review the pharmacy dispensing tariffs and then developed a model to calculate the impact and cost of incorporating varenicline and cytisine through a PGD. In doing so, we used a number of assumptions. So, for example, we considered the stop smoking service data, the ambitions that were set for the local governments for quit dates set for next year, and we considered the cost and impact both at a locality level but also a regional level. Even taking into account our proposed costs for delivering the regional PGD, which include management fees, clinical assessment fees, product costs, the model suggested that across the region there would be a 6% efficiency saving in the total cost of all medications across the year. It suggested a conservative increase in quit rates of just over 4%, and this would result in more than 650 additional quitters per year in the North East. So based on this, the Task and Finish group took a proposal for a regional PGD, which all local authorities could sign up to and could benefit from the engagement of up to 555 pharmacies, as I say, across our region. This proposal was supported and agreed by all of our 12 local authorities. But what did it consist of? Well, in the North East, we have Pharmacy Services North East, or PSNE, I refer to it as. This is the provider company that was set up by local pharmaceutical committees, and it was established back in 2016 to help facilitate the commissioning of services within community pharmacy. Our proposal was that PSNE was commissioned on behalf of all of the local authorities to manage and deliver a pharmacy PGD supply service within the community pharmacies in the North East. And this was based on something similar that we'd done previously to enable a maternity NRT e-voucher supply across the whole of the ICB. So to do this, the proposal included identifying a lead local authority. There would be an MOU in place between the lead and all of the local authorities, and the lead local authority would be the one that authorised the national PGD template through their own governance and procedures, which the other local authorities would then adopt. The lead local authority would then contract with PSNE, as I say, on behalf of all the local authorities, and PSNE would engage with the pharmacies and sign them up to deliver the supply service. They would also develop an e-recommendation template on farm outcomes based on the PGD and provide all of the locality stop smoking services with access to farm outcomes so that trained stop smoking advisors across the region could utilise it and make e-recommendations for clients wanting varenicline. The client would then go to the pharmacy who would do the clinical check, and if appropriate, the pharmacy would then issue the supply. And instead of localities receiving up to 60 different invoices per month from different pharmacies for the product supplies, etc., localities would just receive the one invoice from PSNE, and then PSNE would sort the payments out to the individual pharmacies. There were multiple benefits from this approach. From a local authority perspective, it was much more efficient. Previously, where local authorities had put PGDs in place, it was a lengthy process that required lots of capacity to develop the PGD, to develop and amend service specifications, to engage with individual pharmacies, develop or processes or buy licenses for systems, deliver training, etc. And all of this took a lot of time and capacity within the public health teams, which were increasingly under more pressure with more portfolios to manage. And then obviously having to do that separately in all 12 different local authorities. This approach meant that things could be done just once. It was a consistent approach across all of the localities, and it also meant that there was a singular approach to training could be taken rather than, training being done multiple times in each of the different local authority areas. There was also a huge benefit in terms of from a pharmacy approach. It was a single consistent approach. Staff within pharmacies often work across multiple pharmacies, and sometimes they can work in multiple pharmacies that are in different local authority areas. So they would no longer be subjected to this kind of postcode lottery of, well, in this shop you can offer this, but in this shop you can't. And it would also mean that it was the same process in every shop, in every locality, using the system that the pharmacies were really comfortable with. And this makes it much, much easier for pharmacies and for their staff, meaning that they were more likely to engage. I think what we noticed was when things start to get really complicated or there's various different systems or processes being introduced, that's when we see the pharmacies maybe pulling back and disengaging. But finally, the biggest benefit is to the person who smokes. As I say, we put them at the heart of everything that we do, and this proposal would give them that consistent access to evidence-based first-line stop smoking medications. It would provide them with greater choice and greater flexibility and remove the barriers of having to get an appointment with a doctor or waiting on a prescription to be request to be turned around or only being able to access a certain clinic at a certain time in a certain location because there was a prescriber there. It also, because it was regional, it would also remove the artificial local authority boundaries. So, for example, if somebody lived in Northumberland but they worked in Newcastle, they could access a pharmacy in Newcastle, maybe on their lunch break, even if they were being supported by the Northumberland Stop Smoking Service. So, as I say, much more flexibility there. I just wanted to flag as well that whilst we're working on this regional pharmacy PGD supply service for community stop smoking services, we were also very much aware, as I say, that the landscape of the stop smoking system in the North East was much wider. So we wanted to ensure that Varenicline and cytisine were available in our Trust's tobacco dependency treatment services as well, recognising that people in the community will be admitted to hospital and people in hospital will be discharged back into the community. What we didn't want was a situation where, for example, varenicline could be accessed in hospital, but then it couldn't be continued in the community, or vice versa, somebody being initiated in the community, but then being admitted to hospital and not having the medication there for them. So we have this parallel work stream within the trusts working with our Smokefree NHS task force. We've developed a template standard operating procedure for the provision of both varenicline and cytisine. These have been approved by our task force and they've been shared with the tobacco dependency treatment services across our acute and mental health inpatient services. And the tobacco dependency teams within each of the trusts are currently looking to go through the process of through their internal governance procedures to localise and adopt and ratify them. So this is our anticipated time plan. As you can see, the plan is to launch in early February next year. However, I would be remiss if I said that everything has gone smoothly. We've had lots of enthusiasm, willingness to collaborate across the region and support across the system, from commissioners, stop smoking services, clinicians, pharmacists, LPCs, PSNE, and amongst others. We've made great progress we've have everything ready and waiting to go. We have the MOU, we have the contracts, the service specs, the amended PGD, the recommendation templates, training plan, but it's not without its challenges. And I think, it's fair to say that the biggest challenge that we have actually is procurement, the actual process of within a local authority being able to contract and transact money across to do direct awards, involvement of legal teams. Obviously, there's new rules and new regulations coming out around procurement, and the bandwidth to understand the new rules and how we can move forward with them. So, if anyone anywhere has found an easy solve to this, then definitely please do get in touch. It would be welcome. As I said at the start, this is a work in progress. We have everything ready to go for a start in February, but we still need to work through and finalise with a lead local authority. And if that's not done, then we obviously do risk our timeline being delayed. And I think on that note, I will end it there. Thank you.
Joanna, thank you. I mean, that is an outstanding piece of work. And again, lots of claps coming for you, because I think one of the things with Varenicline and cytisine is because hospitals already have prescribing in, we're used to prescribing medications, it's part of the day job. That's not the case in local government, but our patient pathways straddle both. And for a lot of people, they only access local government. They've not even touched a hospital. So the work that you're doing is just outstanding. And I can imagine that you're going to be booked up to give regional talks. And this, Ash and others have long pushed for regional tobacco control structures to be more mature, as you've got in Manchester, as you've got in the northeast. And this is almost that proof of that kind of concept of regional tobacco control, allowing things to be done once and everybody to benefit, provided you can bring everybody together. And so I know you're not there yet, but it feels like you're within touching distance. So thanks ever so much. I'm sure Ash and others would be keen to hear how this goes, and I'm really going to cross all my fingers, my legs, everything in the hope that you get it launched. So just outstanding. Thanks ever so much.